As my slides are coming up, I'm going to chat about a clinical trial that was done to look at the product that was just mentioned, RBL, or fecal microbiota live jslm, to administer this via a colonoscopy. We've talked about this at great lengths today. C. difficile happens because of a disruption in the gut microbiome. Antibiotics cause more disruption. People get into the subsequent cycle of recurrence, and microbiome restoration by a methodology can help break the cycle of recurrence and also help with colonization resistance, where you don't get C. difficile over and over again and get to a path of health. As you heard earlier, RBL is an FDA-approved microbiota-based product, which is a rectal administration per the label, done non-invasively in a provider's office or sometimes at home, and manufactured in a GMP facility from healthy donor stool. About 150 cc's total is administered into a patient and leads to alleviation of recurrent C. difficile infection. Over the clinical development program, more than 1,500 people have gone through RBL administration. The success rates are upwards of 70% in numerical values, and RBL has had a favorable safety profile. The big question is, traditionally we've been doing FMT via a colonoscopy. It's a liquid product that's been used, and we now have scarcity of FMT available at multiple centers, including with open biome, that is no longer available. So there has been an interest to deliver RBL via a colonoscopies. That can you deliver this to the right side? Can you do this in the usual GI practice? And if you need to do a mucosal assessment of the colon, can you do it at the same time? Paul led a study before this clinical trial that had 10 patients and that had a high success rate of 80% with RBL via a colonoscopy. So for this particular clinical trial, this was a phase 3B open label study where patients received antibiotics and then in an open label manner received RBL via a colonoscopy. We had 41 adults overall who had documented recurrent C. difficile infection, got antibiotics, diarrhea was controlled, and within 24 to 72 hours after antibiotics, they did receive bowel preparation for a colonoscopy and then received the product via a colonoscopy. The primary study objective was to assess efficacy and safety and efficacy when administered via a colonoscopy. Primary endpoint was at 8 weeks, looking at treatment emergent adverse events and also efficacy. And there were secondary endpoints of the efficacy, I should say. And then we also had 6-month data eventually pulled out. We screened 54 individuals, 41 participants were enrolled. The average age or mean age was 61 years. About 90% of participants were female. The average number of C. diff episodes was 3. And right before them, the RBL administration via colonoscopy, vancomycin was the most common prescribed antibiotics. You can go back and read any FMT literature over the years. You'll see similar demographics. So this really simulates what we are doing or what we were doing in the real world prior to FMT not being available as much. Looking at the results of the study, we had 5 treatment TEAEs that were assessed as related to RBL. They happened in 4 people. They were all, majority were GI disorders, as we've seen before: abdominal distension, constipation, diarrhea, and flatulence. They were all mild in severity. Overall GI TEAEs were most common, followed by some people got some infections, again, not deemed to be related to RBL itself. 2 patients had serious TEAEs that were adjudicated as unrelated to the product itself or its administration. Within 8 weeks, there were nobody who had ICU admission or death. So similar safety profile as we've seen in the clinical trials, as you've seen for FMT back in the day, even better because no infections were transmitted. Paul showed the slide earlier. 95% success rate. 2 people who did not have success rate at 8 weeks who were lost to follow-up. And then at 6 months, we had 1 more person who actually had lack of treatment success. So overall, highly successful at 8 weeks and even up to 6 months. We then thought, you've done this to the right side. should we actually do microbiome analysis to try to figure out, have we restored the microbiome like it has been seen in other products in the past? This was an exploratory analysis, 41 people total, 20 participants had samples at all different time points, 18 participants had baseline, and then majority and samples otherwise too. I'll go over the methods briefly. We had DNA extraction, and sequencing was done using shotgun metagenomics. We used the sham pipeline, and then looked at many different indices, and I'm going to talk to you about all of those. We looked at microbiome health index, we looked at alpha diversity, and we compared them to what has been so far been healthy from the Human Microbiome Project. This is one of my favorite slides that you will see following. Here in this graph, you can see what RBL looks like on a spatial composition of microbiome analysis. This is a principal component analysis. As you can see, the blue dots are all staggered together, and the red dots are far away from the blue dots. That just says that people who have recurrent C. difficile infection, their microbiome profiles are very different from people who do not have recurrent C. difficile infection and have been able to be stool donors. So at baseline, it's very different. As early as 1 week, you start to see a convergence of microbiome profiles that were previously in the red dots. They're now these triangles, and they start looking very similar to the donors. So there is an engraftment, meaning the donor bacteria start living in the recipients, which is not something that we see in probiotics. This is at 8 weeks, you see similar convergence. So while there's engraftment early on, those bacteria then, after one-time dose, continue to stay and live in the donor colon. And even at 6 months, you start seeing a similar convergence, and this has been seen in the rectal administration also. So when you're administering RBL via colonoscopy, you get all of that practical ease of doing it. You also have the ability to examine the colon, but in a microbiological way, in a microbiome way, you have the ability to restore the gut microbiome. Now, when we look at different bacterial phyla, there are 2 phyla that are important and correlate with human health. Those are Bacteroidetes and Clostridia. RBL is a whole microbiome consortium. So it's got Bacteroidetes, it's got Clostridia, it's got Firmicutes, it's got everything that is needed by the human gut. And the undesired phyla are Gamma Proteobacteria and Bacilli. If you look at the baseline levels, in recipients, you're seeing low numbers of Bacteroidetes, low numbers of Clostridia, high numbers of Gamma Proteobacteria, and high number of Bacilli. That means an unhealthy microbiome composition. As early as 1 week, you're seeing a flip. In the upper part of this graph, you're seeing Bacteroidetes go up, Clostridia go up, Gamma Proteobacteria go down, and the Bacilli go down, and this is sustained to 6 months, and the composition of these bacterial taxa in the recipient start looking like the donors. We also were able to calculate something called the Microbiome Health Index. This was developed by Ken Blount, which is a ratio of the composition of the 4 phyla that I showed earlier. And here you can see again at baseline, the Microbiome Health Index is low. And as early as 1 week, you start seeing a higher Microbiome Health Index, which just gets maintained up to 6 months. And this has been seen in the other clinical trials of RBL also. You all may have heard of something called alpha diversity. Alpha diversity is the number of different microbial species that are present in a given ecological niche. And here after RBL administration, you can see in the graph that alpha diversity continued to increase from baseline and reached what RBL looks like as a product. The recipients become very similar. In my mind, I start thinking about when these people reach 6 months, they're probably ready to become stool donors themselves because their microbiome composition is really good. How do we do this in practice? Now, you're always thinking about, you've got something in an enema bag, and now you're saying you don't want to give it as an enema, but you actually have to somehow figure out to give it in a colonoscopy. Now, these are graphs and slides that we have published in recent publications in Therapeutic Advances of Gastroenterology. At this time, first of all, colonoscopy administration is not on the FDA label. This is something that would be done under a clinician's discretion. Number 2, the way this was done was we made the clinicians have the liberty, or however you would want, to transmit that product from the enema bag into your scope, and there is several methods. You can take a sterile scissors and you can cut the packet open and have a syringe and draw it out and use those syringes, or you can connect the spike port with an adapter and connect it directly to the end of your colonoscope. Very simple to do in the endoscopy suite. One thing to keep in mind is this product is shipped frozen, and it has to be thawed in the refrigerator and can be done that for up to 5 days. At times, you can also thaw it at room temperature also, but we prefer thawing it in the refrigerator. We do not recommend hot water to thaw it out. And these are two more, I would say, detailed descriptions of how this can be done. As an example, the left picture or cartoon here shows how you can connect a syringe then to the colonoscopy port, and as the scope reaches the right side of the colon, you can then administer the stool. One thing to keep in mind is it's safe to do biopsies if you need to do so while you have the scope in there. I typically do the biopsies on my way in, so that on your way out, you really don't have to stay in for much longer. And the same thing, you can connect this with a port from the bag if you have an adapter. For this study that we did, 40 of the 41 people received in the right colon, 1 received in the sigmoid colon due to technical reasons, but clinicians have the liberty of deciding how they should be administering this product at all. So in conclusion, the CDI scope study demonstrated that RBL via colonoscopy was effective at preventing recurrent C. difficile infection. It was safe. The safety profile was consistent with rectal administration. We were able to restore the microbiome composition, alpha diversity, microbiome health index, similar to how you do it in the rectal administration. These findings support the clinical utility of RBL administered via colonoscopy to manage recurrent C. difficile infection. At this time, it's off-label, but something that clinicians can do, especially if they want to simulate how they were doing FMT back in the day. I can't thank enough all the patients and everybody who supported this clinical trial. Thank you very much. And Kristen, I do have a couple of minutes for questions, though.
Oh, okay. Does anybody have any questions for Dr. Khanna? I told them they wouldn't get any, so maybe they were just behaving.
Kristen, one question that comes to my mind, thank you, is can I start doing this today with a colonoscopy in my approach? I think that requires a multi-pronged approach. You have to talk to your hospital, you have to make sure the payers are going to pay for it, and talk to the patients about it and make sure that you understand this is not on the label. That's the one thing that we have to keep in mind when we start using. Not that it's not allowed to do it, you can still do it. You have to be mindful of these considerations.
Yeah, that makes perfect sense, because of course people hear this and they think, well, sign me up, sounds good.
Patients are asking for this. Patients are asking, why can't I get FMT like my aunt got 5 years ago? So then we say this is probably the closest thing if you want to simulate the entire procedure, like doing it with the scope and all that stuff. Not that the others are any different, but this is probably as close as you can get to the traditional good old FMT.
Yeah, no, I was very pleased to read this study. I think it's a good step forward for the people who need it. People who can't retain an enema. There's some folks who
yes,
definitely need it this way. Well, the participants are behaving, so we're going to let you go.
Thank you very much. I appreciate it.
Good to see you.
Good to see you.